Well, good afternoon. Welcome, everybody, for this session. This is our Hot Topics in Public Health. My name is John Tempte. I'm a long-term family physician and serve as Associate Dean for Public Health and Community Engagement at the School of Medicine Public Health. And we're excited to have people actually here. We have been doing the Hot Topics in Public Health since January of 2020. Our very first one was in person on the topic of the novel coronavirus 2019. And since that time, all of our offerings have been virtual without being able to see people or interact. Our planning committee for this event really thought that if we're going to be talking about loneliness and social isolation, the worst thing we could do is do this virtually. So we thank everybody for your willingness to come in here. And in fact, we made the decision not to make this a hybrid event, to force people to get together. So the topic tonight is all the lonely people, our epidemic of loneliness and isolation. If you're interested in live captioning, please use the QR code up here. All right. And as always, we'd like to start out with a land acknowledgement statement. But I want to really emphasize that when we talk about ethnic cleansing, when we talk about forced removal, when we talk about change of culture, these are all things that can lead to isolation and loneliness. So at least for tonight, when you look through this, also think of it in terms of the context of social isolation and loneliness. The first use of the word lonely in the English language goes back, as far as I could find out, to the early 1600s. And if anyone wants to take a guess who first used this word, I bet you're going to be right. Yes, it was William Shakespeare. And we have to go up another 200 years into the early 1800s to see the first use of loneliness. The very first recorded study that looked at loneliness was in 1948. And as we see up here, the words for Eleanor Rigby, 1966, this is actually credited with popularizing the concept of loneliness. It was the first time in widespread public conversation, media, and so on, that loneliness was discussed. That leads us to last year, the Surgeon General's report on our epidemic of loneliness and isolation. And a quote here, people began to tell me they felt isolated, invisible, and insignificant. Even when they couldn't put their finger on the word lonely, time and time again, people of all ages and socioeconomic backgrounds from every corner of the country would tell me, I have to shoulder all of life's burdens by myself, or if I disappear tomorrow, no one will even notice. Pretty harsh words. In the scientific literature, I found confirmation of what I was hearing. In recent years, about 1 in 2 adults in America reported experiencing loneliness. And that was before the COVID-19 pandemic cut so many of us from friends, loved ones, and support systems, exacerbating loneliness and isolation. And I want you guys just to think for a couple moments here about the last 4 or 5 years. And also, without getting political at all, think in terms of the barriers we've created in our society. Think, into late November at Thanksgiving, when we hear the adage of, well, what do you do when you have a family member who has very, very different opinions? We've created a lot of new barriers out there. And another song, I was going to say recent, but that's actually more than 50 years ago. It seems recent to me, just a marker of my age, I guess. But just alluding to some of the consequences of loneliness when it pertains to substance abuse, and as we'll hear from some of our speakers, other medical issues. So I'm just going to take you through this really quick. This is your exercise, your assignment, and it's just a counting game. And I want you to, 3 questions, and just keep in mind and add, so if you say hardly ever here, you get 1 point, some of the time 2 points, and often 3 points. So how often do you feel that you lack companionship? And then add that number to how often do you feel left out? And then finally, how often do you feel isolated from others? This is the UCLA brief screen for loneliness. And if your score is 6 points or higher, it signals the possibility and likelihood that loneliness may be an issue or an important thing. Well, going on with our program, we have the wonderful event here to have a great panel. Mary Henningfield is Associate Director of the Wisconsin Research and Education Network. Ren engages with clinicians throughout Wisconsin to generate and implement research projects relevant to primary care. And the reason I called Mary for this is I know that Ren has been involved with looking at screening for loneliness and other activities around this topic. Next, Alexis Eastman. Oh, and I have to say that Mary is a close colleague, and both I and one of our other panelists are former directors of RAN. Okay. Next, Alexis Eastman, a physician, geriatrician, and clinical assistant professor at the School of Medicine Public Health. And I'll have to also toss out that Alexis was a mentee of mine years and years ago doing a summer research project on respiratory viruses. But a wonderful person, senior medical director of ambulatory medical specialties for UW Health. She is a director of clinical operations for primary and specialty care in the Division of Geriatrics and Gerontology. Does a lot of things in the realm of geriatrics and has been named one of Madison's top doctors. Emeritus Professor and Dr. and Sir John Beasley, a very good friend of mine and one of my mentors through my training from family medicine and community health. John graduated from Harvard College in 1964, received his MD from University of Minnesota, but John has such an incredible experience with all aspects of primary care, including Peace Corps, including development of the advanced life-saving and obstetrics. He founded and directed the Wisconsin Research and Education Network. And I asked him to do this because he has this intimate knowledge of the use of electronic records, of technology within primary care and within medicine, and both the positives and the negatives. And then finally, joining us is who I used to know as Trady Gatos and now Tracy Wedekine. She returned for this event from her honeymoon. And you just got back yesterday or 2 days ago? Last night. But Tracy is our director of signature events at the School of Medicine Public Health. And when she learned about this topic, she said, I want to be included because she really wants to think about how we strategically plan events to be inclusive, to cut down on isolation, and to increase interactions from participants and audience. So this is our required slide on conflicts of interest and disclosure. We have none. And our thanks to our planning committee who helped put this together. Our accreditation information. So this is set up for accreditation. Our learning objectives are as follows: defining loneliness, social isolation, explaining the effects of loneliness and isolation on health, identify tools that can be used for screening in clinical practice, and apply approaches to lessen social isolation in events and in the workplace. So without further ado, I'm going to turn it over to Dr. Henningfield.
Great. Thank you, Dr. Tempte, and thank you everyone for being here in person. It is great to be here in person with you this evening. So I'm going to talk a little bit about loneliness and social isolation as a public health crisis and the impact and screening in primary care. So loneliness and social isolation, they are related concepts, but they're actually defined very differently. And there's a number of different definitions in the literature, but most people discuss loneliness as a subjective feeling of being alone or isolated, whereas social isolation is usually thought of as being an objective state of having fewer social relationships or infrequent social contacts, or basically having fewer social contacts than what the person would like to have. And it's increasingly recognized that both loneliness and social isolation are public health concerns associated with negative outcomes. And I just kind of wanted to add too, this photo was one that I took when I was on vacation with a lot of family and friends and having fun. And this picture just struck me because it was a person, hopefully someone was going to join them in the other chair, but it just kind of was an image of loneliness that I saw while on this trip. So loneliness and social isolation do have very serious health consequences. And as you can see here, this is also the image that Dr. Tempte showed of the Surgeon General report. And it's available free to download online. So if you're interested, take a look at that. And basically, poor social relationships have been shown to increase the risk of heart disease and stroke. So not only does loneliness and social isolation affect mental issues like anxiety or depression, but it also other physical complications. Social isolation in of itself has been shown to increase the risk of premature death from all causes and increases the risk of dementia. And loneliness is also, as I mentioned, associated with higher rates of depression, anxiety, and suicide. And here's some numbers here where it's, among people who have heart failure, loneliness is associated with a nearly 4 times increased risk of death and also increased risk of hospitalization and emergency room visits. So this is very serious health consequences. And Dr. Tempte also talked a little bit about trends in loneliness and social isolation. And one of the key findings from the Surgeon General report is this trend in increase in loneliness and social isolation actually happened before the pandemic. So possibly due to increased use of social media and the way that we connect with people, but certainly at the time of the pandemic, and you can see here where 2020 is on the scale, things really took off, and because of physical distancing and all of the things that happened during the pandemic. But a recent post-pandemic survey indicates still that more than half of the US adults are considered lonely. And this is a big unmet need. More work and research is done to understand, what works to overcome loneliness and social isolation. So what are the effective interventions? And this is a statement, again, from the Surgeon General's report about, sort of this urgent need to really look at what interventions work, what can we do to help address this problem, which obviously we just know that it has all these physical and mental healthcare consequences, so we really need to do something about it. And the image on the right is one that, again, from the Surgeon General report, and you probably have seen this because it gained a lot of social media attention, that lacking social connection is as dangerous as smoking up to 15 cigarettes per day. And I think that it did gather a lot of attention with that statement. I want to talk a little bit about Wren's work. As Dr. Tempte mentioned, Wren is the Wisconsin Research and Education Network. I'm the associate director. And so we do very pragmatic work in primary care. And prior to submission for some grant proposals that we're working on, we conducted a focus group. It's called the we call it the BOAs, which is the Rural Board of Older Adult Advisors. So this was held back in June of 2023. And it was very interesting to meet with these folks. So we actually got to meet in person in Dodgeville, and they mentioned that loneliness was important to them, that it was something that they recognized that it would impact people's health, and mentioned specifically their quality of life. And they provided us with a lot of feedback about the proposed study, especially the feasibility of screening for loneliness in primary care clinics. So their observation was they knew of people in their community that might have been isolated, but among older adults, they probably had some medical issues, so they were seeing their primary care physician on a regular basis. So they thought it was a great idea to have screening in primary care, because even if they're isolated, they're still visiting their doctor on a routine basis. And they offered a lot of suggestions about approaches to recruitment and introducing the topic to loneliness, as well as the language to describe both loneliness and interventions to patients. And one of the interesting things is people didn't want loneliness to be viewed as a mental illness. And they also viewed that maybe sometimes loneliness is temporary. Like maybe there was a situation that maybe death of a spouse or some other event that happened. And so they didn't want it to be like stigmatizing for people who were lonely. And we also talked a lot about they gave us great feedback on the language, because we asked them about cognitive behavioral therapy, and they said, oh no, you can't tell that to people because cognitive behavior, like that's just too technical, like can you find another name for it? So we had a lot of great feedback on our proposed protocols. And so really, as Dr. Tempte mentioned, screening is very important. So really studying loneliness and social isolation, it can begin with screening. And one of the validated methods, the one that he showed that's very quick and easy with the three questions, the UCLA 3-item loneliness scale. And there are also longer versions, 20-item versions that test not only for loneliness, but include social isolation. And as you notice when we went through the questions, they don't mention loneliness. And it was initially tested as a brief scale. It could be self-administered, but it's also can be effective. It can be administered like during a telephone interview. So this is actually an image of the UCLA 3-item loneliness scale with the 3 questions in the scoring. And as Dr. Tempte mentioned, it goes from least lonely to most lonely. And actually in this image, I put 1 to 5 is not lonely, but technically if people answered all 3 questions, their lowest score would be 3. But definitely if it's higher than 6, then those folks are considered to be testing positive for loneliness. And so Ren has also had some involvement with, it used to be called the Wisconsin Coalition to End Social Isolation and Loneliness, which is a mouthful. We'll call it WISO for short, but now it's the Wisconsin Coalition for Social Connection. And so we're involved with, there's monthly meetings. This organization helps disseminate information about resources. So if you go to their website, there's a ton of information there. And they have been doing projects on screening, and I will share one with you in the next slide here. So this was a pilot project done in Brown County, and the pilot began in the summer of 2022. So sort of, we're coming out of COVID. At that time, we didn't really know if COVID was ending, but during that time, and they did use the UCLA 3-item loneliness scale. And the people that were doing the screening were members with the Aging and Disability Resource Centers, the ADRC specialists. And so they screened from July, or as of July 15th, 2024, had screened nearly 400 people, 368 people. And the screening questions seemed to help open up the conversation for engagement with social activities in the community, and also the programs offered by the ADRC. And so they thought that they kind of concluded that the screening, it was feasible. So this can be done even by community organizations, but it wasn't consistently used in this program. And so we have started this was a small project. It's ongoing, but we used the UCLA 3-item loneliness scale. We looked, because it is embedded in the UW Health electronic health record in Epic. And we wanted to look at the number of times it was accessed in primary care. So this was in family medicine and then general internal medicine. And we looked at the numbers of patients, and as well as the percentages of people who met the criteria for loneliness. In other words, that screened positive for loneliness. And we wanted to look at differences between younger and older adults. And we also did some other analyses like looking by clinic and also like trying to look at if there were different percentages of patients served by rural clinics. And then finally, we sort of identified which primary care clinicians access the loneliness scale. And so we wanted to know, like, was there a high frequency of use among just a few clinicians, or were there a lot of people using the loneliness scale? And this, again, it's still in progress, but this is like an initial preliminary data from the chart review. And I think what's interesting is that the younger people, 18 to 64, about 40% screen positive for loneliness, and it's a pretty similar number for those that were 65 and older. But of course, these data offer more questions than answers because we want to know, like, why did clinicians decide to test or just screen a particular patient? And once someone was screened or they screened positive for loneliness, then what did they do? Because we don't really have like a algorithm or this is the intervention that should be done for this patient. So we have a survey it's still open, it's ongoing. And these were some of the things that we wanted to know. As I mentioned, why did you screen for loneliness? What did you do? And in some of the preliminary answers were very interesting because some clinicians said, well, they didn't really do anything. They didn't really have anything to offer that patient. Some did a referral to a behavioral health consult, and some did things such as they asked the patient to come in sooner than they normally would, just to chat with that patient. And what I have in red here is, of course, if we screen for loneliness, we need to be able to offer patients evidence-based interventions, to address loneliness and social isolation. And so we have a number of projects, some new proposals to evaluate interventions. And some of the things that have worked are cognitive behavioral therapy, and then also social navigation, although I really like the term social prescribing. So that's sort of meeting with people, trying to understand what their needs are, what their interests are, and then connecting them with resources within their community. And part of that is also overcoming barriers. For example, if they're older and maybe they can't drive anymore, do they have trouble getting to events? Are there community resources that can help them get a ride? And actually, during like the BOA's focus group that I mentioned, there were things such as someone mentioned their adult children and grandchildren moved away for another job, so they weren't close by anymore. And so they wanted to take an extra step to connect with them, and they went to some resources to learn how to use social media like Zoom and so forth. And so then they were able to, make that connection virtually. And one intervention that's not on here, but one that is also getting a lot of publicity is, phone calls. So this was a study that was with people who were on Meals on Wheels, and they were asked, or they worked with people called them basically every day for a week, and then they could choose the frequency of the phone calls. But within 4 weeks, it was amazing. They had differences in the UCLA loneliness scale within a month's time. So it kind of shows that some interventions, even small steps or seemingly small steps, can work to address loneliness and social isolation. I think that's my last slide. Thank you very much.
All right, so we'll trade out. I'm Alexis Eastman, friendly neighborhood geriatrician, and we're going to talk about social isolation and loneliness in older people. This is The Sorrowing Old Man, painting by Vincent van Gogh. I thought it was an appropriate painting for tonight. So we're going to recap really quickly just on the definitions that we're discussing tonight. So loneliness, the subjective feeling of being alone or isolated. So really the distance between your hopes for interactions with others and the actuality you're experiencing, as opposed to social isolation, which is a much more objective state of having few social relationships or infrequent social contact with others. In geriatric populations pre-pandemic, these are all my numbers, the prevalence in the community of loneliness and social isolation were thought to be about 19 to 29%. Which goes up astronomically in economically deprived locations, either deeply urban or deeply rural locations. It can be 36 to 80%, depending on which study and which location you're looking at. Some of this work was done in rural and urban England, UK, but others were done in Canada and the US. And in congregate facilities, both assisted living and skilled nursing facilities, the prevalence of loneliness is about 61%. And there's a lot of literature that talks about how people who enter into congregate living facilities expect increased socialization and decreased in loneliness, and then do not experience that. So that distance is quite great for them. So who's at risk? So this is one of those busy, wonderful tables that comes out of a nice paper, but it's a good table. Socio-demographic factors include increasing age, being female, having a low income, living, as we said, in long-term care, living in economically deprived, isolated areas, people who have multiple comorbid conditions. Hearing and vision loss is a big driver of loneliness and isolation, as it increases so many barriers for older people to interacting with others. Frailty, which we're going to talk a little bit more about, and cognitive impairment and functional impairment, again, physical barriers to accessing others. People who live alone or far away from their family, people who cannot drive or access transportation, people who have not created friendships across their lifespan, and then people who are caregivers, because being a caregiver is an inherently isolating event outside of your caregiving group. And lots of life changes, which, as we all know, happen as you get older, sometimes catastrophically. What's the impact in older patients? So there is a distinct increase in mortality associated with loneliness and social isolation in older patients, 26 and 29% higher than in the non-lonely, non-isolated populations. Pull out that same statistic of 15 cigarettes a day or of having alcohol use disorder. I don't actually know any patients who smoke exactly 15 cigarettes a day, but I like the number. On the flip side, people who have strong social networks and strong social relationships have a 50% survival likelihood or advantage over people who do not. So there's benefit to increasing socialization that actually outpaces the increase in mortality of being lonely or isolated. We also know, as Mary pointed out, that being lonely and socially isolated increases your risk of getting dementia. I wish we knew why, but it does. So people with lower social participation have a relative risk of 1.4. People with few social contacts have a relative risk of about 1.6, and loneliness as defined by the UCLA loneliness screening tool of about 1.6. Additionally, people who are lonely and isolated decline. So that's an interesting correlation. They have a higher risk of functional decline and mobility decline. And so if we look at impact, people who are lonely and isolated fall more, have more heart disease, have more malnourishment, are much more vulnerable to elder abuse. Right? As you can imagine, that makes a lot of logical sense. They go to the ER more, they go to the hospital more, they go to nursing homes more. They become more frail. And so frailty is a big issue in terms of loneliness and social isolation. If we define frailty as an age-related clinical syndrome of deterioration in physiologic capacity and decreased functional reserve, then you're suddenly more susceptible to disproportionate functional decline, say that 10 times fast, following a stress event. And that goes along with dementia, hospitalization, falls, functional debility, increased mortality, which in truth doubles to even quadruples in people who are frail compared to older people who are not frail, depending on which study you read. Loneliness is clearly linked to frailty, social isolation a little more dicey in terms of the data. These are the numbers I found for COVID, not the Surgeon General's numbers, but I'll go along with his numbers. They seemed good numbers. Loneliness pre-COVID, as I said, in older people was 19 to 29%. During COVID was 30 to 60. And lonely people had a 1.65 hazard ratio of developing depression in older patients. Why is this important? I don't think I have to tell you why depression is important. We think about depression in a lot of different groups. I think it's always really important to remember that 18% of suicide victims are over the age of 65, right? With a very high completion rate. So older people who attempt suicide are much more likely to succeed than younger people. So I don't want to end on that sad note. We'll talk about interventions that have data behind them, shall we? So there are some good studies about interventions. The data is mixed in a lot of them, but there are interventions that include social facilitation, clubs, day programs, video conferencing, interactive video games. I think that, like, I'm of the generation of like Final Fantasy and World of Warcraft, right? And so like I imagine a bunch of older people playing World of Warcraft, and I'm not entirely sure how I feel about that, but it is funny to think about. But when you look at the relevant results in meta-analyses, having some sort of psychosocial or educational focus, a group activity that it has a planned mission or activity that's important, it can be a more valid intervention. Psychological therapies, humor therapy, I tell terrible jokes. I think I'm giving people therapy all the time. Mindfulness-based stress reduction, cognitive enhancement, reminiscence, right? Writing your stories. These are more effective if they are led by trained facilitators. And it's a little difficult to determine the effect size, but they're more effective if you've got someone who is facilitating. Animal-based visits, including robots. You know, I run a nursing home. We've got lots of robot animals. People seem to like them. They only get annoyed because they won't fetch. Both are likely effective. These studies are really only in long-term care. There's not a lot of, I brought you a cat to your house kind of thing. The cat would probably not like that. Physical activity, exercise, nutrition, these are again best when they're facilitated. Healthcare referrals, preventive prescribing, again, something that's best if it's facilitated by a trained individual. Befriending, the telephone support that Mary was talking about, volunteer visits. They may not be as effective as these facilitated interactions, but they can be the only option for people, and they can be solid and valuable interventions. And then finally, skill development and leisure activities. I'm always telling patients to take on challenging new activities, learning a new language, playing music, gardening, etc. They seem to do as much good as exercise in some interventional studies. So best practices, data is a little bit mixed on which of these is better than any particular other intervention. It's likely multifactorial, but the best data seems to be for exercise, social clubs, animal therapy, better if facilitated. There was actually an interesting study that looked at a program that mirrored Wisconsin's Stepping On program. If you know about that, it's a wonderful falls prevention program. And there was another place that did something almost as good, and that was an effective preventer for loneliness. I know Mary talked about local resources and websites. These are some of the big national interventions in the US, the UK, and Australia. They let anyone look at their website. You don't have to live in Australia, so it's okay. So I put thank you in questions, but we're holding the questions till the panel. But thank you.
Well, the loneliness and isolation can be a problem for healthcare professionals as well. And I want to ask, how many of you have seen this picture before? The doctor's way over in the corner. He's on the computer. The technology is distracting him from the 7-year-old girl on the exam table. And this is important because for healthcare people, relationships are important. And it's not just the doctors, it's the staff and the other people in the office. And there's such an opportunity missed here. But it doesn't have to be that way. We can use the technology to exchange information, to bond us together. Notice the eye contact here, and we can, important stuff. And this isn't really new stuff. John Tempte had alluded to this, and when I was in college, we all sort of had to be required to read The Lonely Crowd by David Reisman and all. But we can be lonely in a crowd too. Look at this. The only relationship is with her smartphone. And again, it doesn't have to be this way. I was talking to one of our medical assistants when I was still in practice, and she said, well, the administration wants us to communicate electronically. And Sherry Carl said, but I like talking to people. I like being with people. So the electronic can be very useful if the talking isn't available. So, but we can have synchronous analog communication, people talking to each other and laughing. I've at one point proposed that we have our industrial engineers measure the amount of laughter in clinics. And my hypothesis is that the amount of laughter between staff, physicians, patients would directly correlate with workforce satisfaction, quality of care, and decreased feelings of loneliness. So I think laughter is important and maybe the best medicine. But the technology can interfere. Here we've got a team who's, obviously making rounds in the hospital. And we introduced the electronic health record. And by the way, let me stress that the problem isn't the electronic health record. The problem is the way that we and our systems use it. And that's an important differential. This is an amazing graph. And if you look at the first one here is with conversation and computer physician order entry before the computer, and the second is after. And look about the third or fourth line from the bottom. You get these long strains of magenta. What are those? Those are people talking to each other. Those are rounding. And you look after the electronic health record gets introduced, all of this is chop chop. It's broken up. So the electronic record here has disrupted the personal relationships of the clinical team. And that can happen here. Look about in the middle here where it says orders. And this is the amount of time spent in the electronic health record by our colleagues, Brian Arndt, Mark Mysick, and Adam Rule. Important stuff, but this is increasing. In other words, when you're doing an order with a patient in the room, you are now disengaged from that patient. And I checked, I was pretty good at Epic. It took 1 minute and 6 seconds to order a chest x-ray. That's 1 minute and 6 seconds I was disengaged from the patient. I was focused on the computer. So one of our colleagues, Jennifer Edgoose, who fortunately for New Mexico and unfortunately for us, left to be chairman at New Mexico, but she talked about the contiguity, the face-to-face relationships important in medical care. Really very interesting conceptual thing. We talked about continuity, comprehensiveness, all that, but contiguity, being there, and maybe even touching people. Mangione, out of touch. And the touch skin is our largest sense organ, the most interactive of all senses, laying on of hands. And then in the next paragraph, he goes on to mention, some can eliminate or translate their need for touch into pet ownership. It seems to me that dogs and cats are beginning to have a fair amount of input into this conference. So, and John Fry, our colleague, wrote about professional loneliness and the loss of the doctor's waiting room and the importance of having meetings that are unstructured, that you can talk about how'd your kid do in soccer, or how's your grandmother doing, all of that stuff. And yet we have lots of meetings which are very structured, nice, crisp agendas. We're going to do this and this and this. And the problem is that maybe, as one cynic said, a meeting is an event where the minutes are kept and the hours are wasted. It might be a little harsh, but so anyway, we need meetings that are not scripted and not structured, like this one, facilitated by some liquid. And these are some of my former research colleagues. Shared, creative, meaningful work without structure and just relating to each other. And so, though, if all else fails, get a dog.
Hi, everybody. Thank you, Dr. Temte, for inviting me to join today's panel. I am Tracy Wiedekind, formerly Gatus. I use she, her pronouns, and I'm the director of signature events here in the School of Medicine and Public Health. I'm a medium height white woman with curly brown hair. Today I'm wearing a tan sweater and black pants with a plaid blazer and a wedding ring. Today I'm speaking about intentional planning to reduce isolation at events. And I intend to share with you 10 habits to create gatherings that promote social connection. I myself struggled with social isolation during the COVID-19 pandemic, during lockdown, and it got me thinking about what connection would look like at the events that I plan. Like, how could I be of service to this? So I came across the same Surgeon General's information that the other panelists have spoken to you about today. And those things really jumped out at me through the news media, through podcasts, through articles that I came across on social media. And I was really surprised to find these facts in the Surgeon General's warning that everyone has referenced today. And I wondered how I could use events to be a catalyst for social connection. So what strategies are event professionals using to promote social connection and community? These come from my lived experience as a planner and as one who attends events, as well as a few key authors and influencers who have really expanded my thinking on using events as gathering and as a platform for reducing and combating isolation. When I say today event, I mean gathering, I mean dinner, I mean conference, I mean party, I mean meeting, I mean all of the above as one, those are all synonyms. So whether you're planning your kiddo's first birthday party or maybe an academic conference or even having friends over for dinner, I personally believe that these habits are critical to creating the circumstances for connection to flourish. So the first principle today is that we deliver joy. If you're an event planner, I believe that you're delivering joy. I was at the Academic Event Professionals Conference last year, and a speaker reminded us of this, and I was like, what, me? I deliver joy? And the reason I think that this is true is that we're creating spaces for gatherings of folks who are sharing a common purpose, participating in a ritual, or celebrating a particular rite of passage. We're taking people out of their everyday routine. We're definitely making a space where we're the captain of creating that space and how it fosters connection. So we're the captain of that ship, and we have the opportunity to create and shape that. We're committed to planning a gathering about something. Dr. Beasley just referenced sort of these wasteful meetings. And I don't even remember how I was introduced to this book that has literally changed my life. Raise your hand if you know Priya Parker's book, The Art of Gathering. Okay, I'm obsessed. We'll talk after. I love Priya Parker. But I think she really creates a unique roadmap for folks who are seeking to make their gatherings better. She has been my North Star for better understanding on how to convey an event's purpose, which comes right at the invitation, right? Here's what we're doing, here's the time, here's the place, here's what needs to happen. And when you know the purpose, you know who should be there. And to me, when you know who should be there, you know how to connect them. So Priya Parker, from her book, The Art of Gathering, says, when we don't examine the deeper assumptions behind why we gather, we end up skipping too quickly to replicating old, staid formats of gathering, and we forego the possibility of creating something memorable or even transformative. Priya Parker says that your purpose must be specific, unique, and disputable, and I tend to agree with her. The who is often tied to the what, she says, and specificity sharpens the gathering because people can see themselves in it. So an example might be, and this is an example that Priya gives, her friend Carol, right? Carol had a bumper crop of basil, and she specifically made a party where she could invite her people over. They had basil mocktails. They ate handmade pizzas topped with piles of fresh basil. They sat in her garden. So it was a specific purpose. It was unique, and it was disputable. It was not about tomatoes. It was not about mushrooms. It was about basil, disputable. So the third thing I think we do is we design for introverts with pro-social behaviors. We define pro-social behavior as voluntary behavior intended to benefit another. So often we think about preventing things from going wrong on an event, but I would argue that artful gatherers design rules that make things go right. So for example, I have a guest who's coming today who needs a gluten-free option, and I've provided it. I've designed for that person's attendance. Another example might be that you write your question on a card and hand it in, right? An introvert maybe doesn't want to speak up and ask the question or come to the microphone, but everyone can access this. They can write their note on the card. It works for an introvert. It works for an extrovert. It creates the rules of the gathering to foster social connection for the most types of people. The fourth principle is that we rely on the principles of universal design. So maybe we're all aware of this knowledge, but universal design says that, quote, the design and composition of an environment so that it can be accessed, understood, and used to the greatest extent possible by all people, regardless of their age, size, ability, or disability. So there are 7 principles of universal design, and I'm going to cite some examples of what this looks like in events. So principle 1, for example, equitable use. Closed captioning. It helps the understanding of all people. not just those who are deaf or hard of hearing. Principle 4, the principle of perceptible information, talks about things that we can see, right? Give how we receive information. Large scale signage, directional signage, those are important for everyone. They're not just for a particular unit of the people. Principle 7 is to make reach to all components comfortable for any seated or standing user. So was anyone at our diversity summit a few weeks ago? Great, awesome, thanks for being there. You saw an interactive display at the end. It was a disability pride flag, and we asked people to capture their key learnings on a Post-it note and put it on the same flag color, kind of make this interactive art piece. And we needed to put it at an appropriate height for those who are using wheelchairs, and even had to move some things around so folks with wheelchairs could approach the flag itself. So this is an example where we're making, I think, anything comfortable for seated or standing users. The next principle that we're implementing here is that we're judicious with technology. In her book, 24/6, The Power of Unplugging One Day a Week, author Tiffany Schlein asserts that technology can sometimes hinder personal interactions. I would tend to agree. What would happen if we invited at the beginning of our presentations for people to close their laptops, silence their phones, and introduce themselves to one person they didn't know? Kind of old school, but it's definitely it's something that we have lost since the pandemic, is sort of an icebreaker or a turn to your neighbor thing that happens. We could bring that back to help create social connection. We're creating accessible spaces, or at least we're attempting to shed light on our blind spots. One example of this might be to prepare your space for chairs that have no arms for folks with bigger bodies, right? We need places that people with all different shapes and sizes of bodies can come to our events and have a seat and be comfortable. And not only just that, for an example, but this whole list of things like all gender restrooms, lactation spaces, considering the time of day for people who have childcare needs. We're creating a space where people can, we're creating circumstances where people are able to attend based on their given circumstances of their situation. We're considering costs and barriers to attendance, and maybe we're offering a hybrid or synchronous attendance as well. All right, number 7. We're setting the physical space to promote conversation. Maybe we're putting out conversation cards as topic jumping off points on the tables in the atrium for you to meet a new friend. Maybe we're setting up the chairs and the couches for small seating areas like we have in the atrium. Or maybe we're setting up a buffet that is, the food is on the buffet so that we're having a shared meal experience as we're interacting about the delicious strawberries that we're seeing. The next thing, number 8, we're building in time for repetition, reflection, and white space. In her book, The Non-Obvious Guide to Event Planning, author Andrea Dreisen asserts that our event and conference schedules need the key concepts repeated within the first 2 hours of their introduction. These are for adult learners. So time for reflection or reflection with a partner is itself social connection. And this white space or downtime in a schedule is necessary for more organic connections to form. Dr. Beasley talked about this. If we're jam-packing an agenda full, we're really not creating that space for organic conversation. Number 9, we're champions for what if? What if we do this? What if we try that? We keep throwing out things and seeing what sticks. Casley Killiam, MPH, the author of The Art and Science of Connection, asserts that social health is the missing component to well-being, that we focus on our physical health and our mental health, but Killiam suggests that fostering our social health can help us live longer, live happier, and live healthier lives. To do that, we ourselves as event planners or expert gatherers need to be walking the walk of intentionally seeking connection, building relationships with experts, other event practitioners, and event attendees to ask them what works and to build these habits. This requires continuing to ask, what if? What if we try pairing people at registration to be event buddies? What if we bake time into the agenda for a reflection of our key takeaways, or a pair and share of people's understanding of the topic? These conversations promote social connection. I even heard of one event person who is putting color coding on her cups. Has anyone seen this? Like red, yellow, and green dots. When you go get your coffee, you put a dot on your cup, and red means I want to talk about this topic, and green means I want to talk about that topic. So you immediately see in the crowd, oh, there's my person. I want to go talk to them about mechanical engineering or what have you. Number 10, this maybe isn't as much of an advice piece as an invitation for more conversation, but I believe that we are, or I am, seeking partners to become the lab for measuring these improvements in social connection by evaluating the effectiveness of these habits. I'm seeking some partners to discuss this further or develop some guidelines or surveys to see if these strategies are effective at events, because I think we're sort of, as I said, the captains of the ship in this area. I'd like to further fine-tune the practices and implement stronger systems for creating social connection. And I intend to introduce these concepts to our community of practice that I founded about 4 years ago for the Event Producers Group to help them create capacity in fostering connection at their events, and also working with local and national organizations to help implement these strategies for social connection. Thank you so much for our time together, and I'd love to talk with you at the reception.
Come up to the table to entertain questions. I just want to make a couple points here. First, early on, Tracy was very instrumental in being very intentional about how we do this. We're coming back for the first time with this symposium in person, but the intentionality includes things like name tags. I wouldn't have thought of that. And in fact, last time we did this in person, we didn't do that. Tracy was very consistent that we have a dessert bar out here. Why is that important? Because it brings people together. And in so many different ways, Tracy was instrumental in not only giving us ideas, but actually walking the walk. So I want to give thanks to that. I also want to give thanks to all of our presenters that without ever going through this once, we kept it beautifully on time. And we do have time for questions. And if you don't have questions, I have a whole list of things that I've submitted previously. But we're open for any questions. And we have some sort of microphones that will be passed around. So,
oh gosh, my microphone is on.
I guess the last thing I'm going to say is, with this topic, one of the important points in the Surgeon General report, and I think we heard it multiple times, is we don't have answers for many of these. We don't have a good evidence base. And this is an area that is ripe for a lot of good questions, a lot of good research, but there's an incredible need out there as well. So we'll open it up to any questions. Don't be shy.
There's captions, so I'll have you speak into a microphone.
I just want to know if anyone can speak to kids. I work for the Office of Children's Mental Health, and so obviously we're real concerned about kids. And we look at stats that say our young people are 2 times more lonely than older people. So just where do kids fit in all this?
May be ironic, but I actually have a comment as a geriatrician. I don't know much about this area, but I do know there are some really interesting studies out of, I think, Montreal that looked at strong grandchild and grandparent dyad dynamics that showed if you have a strong grandparent-grandchild relationship, you have less depression, decreased childhood mortality, and improved grades. So there's my one comment on that one.
And I'm going to follow that up with an observation. I had the good fortune of being part of the Wisconsin Ideas Tour a couple of years ago. And we were up on Door County and visited a school district there where they intentionally paired at-risk students with elders from the community. And it was the same thing. The elders benefited greatly, but the kids benefited even more in terms of having a community member, a mentor, somebody they could, outside of the family context, share things with. And so I think, as Dr. Eastman pointed out, this is really an important area. The other thing with children is you're absolutely right. The rates are sky high. And there are so many things out there that are leading to, one of the questions we had written in was in terms of young people, the whole area of climate change. And there's a linkage there that goes through anxiety. And people who are anxious are much more likely to be lonely. And people who are lonely are more likely to be anxious. And climate change and awareness in young people is really driving a lot of anxiety. So there are so many good questions out there. I don't think we gave you a fair answer, but we tried.
Any other questions?
Thank you. I have so many questions, but I'll just ask one, maybe two. Tracy, I really appreciated your presentation around event planning and just the mindfulness that goes into not just the content that's being delivered, but the experience that people are having. And I wanted to ask, and you're the kind of only person that talked about introversion, so shout out to the introverts in the room. All of this, I came here because I'm like, are they gonna include us in this? Because we really don't wanna talk to people. And so there's like, we live in a very extroverted society, and I feel like the introverts, we like solitude, we not be lonely, but how we engage is different. We're more likely to do a parallel play version that gives us the same benefit versus an actual talking to people interaction. And so as you think about event planning, for all of the wonderful ideas that were presented, for those who just want a parallel play, we just want to be in the room, may not want to have a whole conversation, are some of those things, can people opt in or opt out? And how do we help people who are designing events to not jump all the way to the left and say, well, everyone has to have this whole conversation versus creating that optional engagement so that those of us who are wired a little differently can still benefit, but not be forced into these extroverted things that make us feel equally uncomfortable?
Yeah, that's a great question. Thank you. I think it depends on the event. I would be hard pressed to have Dr. McIntosh or Dr. Petty tell me that a student who was introverted and didn't want to attend the white coat ceremony could simply opt out. I mean, I guess they could, but it would be difficult to sort of process like creating an advertised space for if you also feel introverted, please feel free to opt out of graduation. Like we don't necessarily name it that, but you could do that, right? You don't have to announce your match at match day, right? But for a conference experience, I think, we gave the example of writing down your question on a card and having it read out loud by someone else. I think the same invitation can come from speakers or facilitators to say, we're going to do a pair and share activity. If that's not your jam, I invite you to reflect on these prompts solo. And, I'm available if you want to bounce ideas off of me. I think we can sort of change our language to create the invitation in a different way than mandating, you must go out there right now and tell Shiva Bidar your key takeaway. No. You can go out there and write it on a sticky note. You don't have to talk to anybody unless you want to, but we still capture the same information. I think it is the captain of the ship who has to create those rules. Priya Parker talks about that a lot, creating the rules of engagement for the situation that we're in. I think it depends on the kind of event it is.
Should be being able to add in commentary here as well. And one of your slides, Tracy, had the word or the phrase white space. And to me, that indicates that you create times, as also Dr. Beasley mentioned, that are intentionally not scheduled, where you have that freedom, if you wish, to go sit in the corner and enjoy the solitude. Do I enjoy doing that? Absolutely. But it also gives me the opportunity to sit down at a table with people I haven't seen for weeks, sometimes months, and have a conversation asking, how are the kids? How's the pet? How's your spouse? How's your clinical practice? Things like that. And I have found the trajectory over time is we do less and less of that white space and more of the highly structured and oftentimes directly delivered information that I could actually sit down and go through a PowerPoint on my own. So I think that intentionality is so very, very important with the guardrails on, that people don't have to do anything, but have a lot of opportunities to do whatever.
Yeah, just a quick follow-up on that. If you think about, this is tacky to say, but stay with me. Events are expensive. Your time is expensive. It's expensive for all of you to be in this room right now for 90 minutes or whatever it is and stay for the reception. So I think there is a pressure from, at least at the university, I've been doing this for 10 years now, to jam pack it in, right? It's gotta be a CME credit. We have to make sure it's worthwhile. What are your learning outcomes? Is it worth people's time? Because this is expensive, right? And I think the more that our event sponsors, so in this case, people like Dr. Tempty, or in the case of, you know, maybe the white coat ceremony, Dr. Petty or Dr. McIntosh, you know, whoever my key stakeholder is in my situation, for those people to say, yeah, white space is okay in this situation. Like, how do we create white space? Because there is a pressure, I think, on, I don't know, Jenny, if you feel this way too, there is a pressure sometimes when an event sponsor wants us to plan something that we got to book every minute, and it's 5 minutes to get everybody upstairs to the ILC or whatever. So it can help if the event sponsor is keyed in and on board with those, that position as well.
Yeah, thanks everyone for the conversation. I'm Barb Anderson. I'm the director of the Office of Continuing Professional Development. And I think my question is, I think, a little bit for Tracy, and I know you've done some work in this space, but one of the things that we're seeing for health professions, conferences, and other educational activities is trying to balance the need for people to attend in person and the convenience of being able to log into Grand Rounds online. And I know we're hearing from some department chairs that they're wanting people to come back in person for that networking piece of it. And so, you know, we struggle all the time about how to advise planning committees about whether or not activities should be held in person or hybrid. And you know, when people do show up in person, we hear anecdotally, we forgot what it was like to be able to be with our colleagues and curbside consult and have a quick conversation. So I guess the question is for you, anyone on the panel, how do we facilitate that connection in the virtual environment? Because I don't think it's going away. And I don't think that we can ignore it. I think this is a great opportunity to remind people that it's great to get together, but I think we have to figure out how we help facilitate networking in the virtual environment too.
Did you have a thought, Dr. Beasley? I could hear the wheels turning.
It's because my brain is rusty.
I think so.
Oh. 1, 2, 3. Okay. At least in the medical world, there's a feeling that the telemedicine works reasonably well much of the time, and better if you've known each other ahead of time. So if this is somebody where you've had physical contact with them as a patient, they've had physical contact with you as a physician, the contiguity that Jennifer Edgar's talked about, then the telemedicine really can work moderately well. And I think that's same true for other professionals. I do more Zooming than I want. But usually it's with people I've known previously, I have some connection with, and I think that facilitates it. So the Zoom can be an adjunct, but not replacement for the one-on-one personal contact, in my opinion.
And there are, of course, as I'm sure everyone, as I'm sure you know, a list of best practices for running meetings. I think the thing that I run into, and I think you're mirroring it there, is what to do in the hybrid situation, right? When you've got an audience that's in person and an audience that's online, and how do you as the presenter or the discussant kind of meet both parties? And I think that involves a lot of preparedness on the part of the presenter to speak to the camera wherever it magically is. Mm-hmm. So you have to know where the camera is, and to make sure that someone is sort of assigned the role of attending to that virtual audience to make sure you're not going to have them all have their cameras on because that would just be this weird like hall of mirrors. But to make sure their questions are being tagged and brought to forefront. And I think you can't really necessarily create the Grand Rounds breakout networking that happens virtually, but you can at least attend to that audience.
And Dr. Eastman, I would actually, I agree with you, and I would add that there's actually a third event happening. So it's the in-person event, it's the hybrid event, and then it's this third space of how the virtual and the in-person people are or are not connecting. It's a third way to have to manage. And you know, at the risk of failing on Monday, see how we do the faculty staff meeting. We attempt to, you know, create a space in the room for the guests. And I think this one, Jenny Wright, has like cake and an award and the whole thing. So yeah, so we have, you know, we're attending to our in-person guests. We're attending to our virtual guests through a chat moderator who's welcoming people and saying hello and things like that. You know, but it gets to the point where truly, if you can't do it well, and Barb, you know, I feel this way. If you can't do it well, don't do it. For example, the Diversity Summit breakout sessions did not have a hybrid component. That would require an in-person staff, a virtual staff, a moderator, and someone who's blending those two people for 3 different rooms concurrently. That's 6 people. Plus, if there's anything that goes wrong with the technology. So if we can't do it well and be sure that we can execute, we should say, as we did here, this is an in-person event only, and we know we can do it well.
This is a great event. Thank you so much for all the expertise that's been shared. I have a question for any of the panelists about whether you're aware of any research that looks at links, connections between, and I'll try to navigate this carefully, societal strife and polarization and social isolation and loneliness. We do see a correlation between the advent of social media and increase in loneliness, but you could argue that one drives another. One hypothesis could be that people are becoming more isolated because there's more risk in talking about various topics. You're not sure how they might be received in a very polarized society.
I was going to take a stab at that. We did a project that was, we interviewed clinicians, physicians actually, that were working in rural clinics during the pandemic. So it was more reflections on the pandemic, but actually political issues came up a lot. And that was one of the sort of challenges that they felt more distance from their patients. And so sometimes, and it changed their view of certain patients because they knew like if someone was, you know, interested in ivermectin or some of the, you know, really these conspiracy theories, like talking about 5G wireless is like harming them and all these things. So that, you know, their views of that, but the political diversity, and they also felt like that contributed to like their own disconnection from their community. And sometimes some of their other roles, for example, many had roles as, you know, they were medical advisors for their school system. So they would give advice to the school system and they didn't follow it because they had different, you know, beliefs. And a lot of it was, you know, thought to be tied to politics. So it was very divisive for them. Our sample size was very small, but it was very interesting. And they did attribute it to these political events. And then there was things where the, you know, even within, you know, different families. So some of these primary care physicians had treated like different generations of families, but if someone had one political leaning and then the rest of their family had another, that just caused, you know, additional disruptions and, you know, and feeling just very isolated even from their own family members.
I was wondering in the clinical space, you know, so I live in the pulmonary world, and I've always wondered if some of the benefits of pulmonary rehab are actually the connective group atmosphere. There's some exercise, but some of these groups stay together like far after, you know, the sessions end. Is it twice a week of being together? In your clinical world, do you see a vision of some group sessions, group visits with collective disease states, honoring HIPAA, of course, but, you know, bringing people together to talk about some of these things and create connectivity that might create some connections?
I'm not personally involved in the group work. I know that that's been done with specific entities such as diabetes. And does that decrease loneliness? My guess is the answer is yes. And it may be more centered, sort of disease focused than are you lonely focused. And John, I don't know, maybe a better sense of that, what Brian and others are doing?
Yeah, I don't know of any good studies. I think that's a really worthwhile question. And oftentimes we will ascribe benefit to what we as clinicians are putting out there, when in fact it's that relationship or the relationships. I can talk about my own practice, and there are people that I can honestly tell you I never did anything very good medically for them, but through the relationship and acknowledging them and doing things, for example, wishing them a happy birthday on Facebook. The benefits, I think, are profound, and that connectivity. And when I hear a patient saying, you were the only person that believed in me, and you helped me get through a rough patch. Those are the things that I think are invaluable in clinical practice. And I dare say that, following what Dr. Beasley was, there are so many factors in practice that kind of drive us away from our patients, be it, whether or not you're tied into the screen or you're limited in terms of the time for the visit and so on. And so I think your avenue of inquiry is really profound and really important, and something we don't know enough about, but we should invest more time in trying to learn. I'm going to just take that as a segue just to mention one other. We had a question in here about what advice can you give to medical students? And the thing that really strikes me is we're living in a world where clinicians, be they family or physicians or physician assistants, nurse practitioners, physical therapists, you name it, the level of burnout is really, really high, okay? I think my department hits about 58% of people burn out. One of the attributes of burnout has some very strong social issues in terms of feeling disconnected from your family, disconnected from others. And that's one of those things that burnout is bad to begin with. But I think there's really an association between that burnout and isolation and loneliness. And those are things that I think are really, really important that we as clinicians focus on. Are there other questions?
Yeah, thank you for the wonderful presentations. I have a question about maybe research angle on this. So it's about, we're talking about social isolation and loneliness, but as several presenters have pointed out, they're not the same. And one of them seems to be more the subjective emotion of feeling lonely, and the other one is a more objective measures of social connectedness. And so I can't help but think of this as like a 2x2 matrix of like high-low. And is there something that can be learned to look at, like people who maybe lack social connection, but or would objectively be socially isolated, but don't experience that as loneliness? Or maybe the reverse, somebody who has little, yeah, you see where I'm going with this. So I wonder if something could be learned from that, which might also address some of the points that have been made related to like children who have all these social connections via social media, but still feel lonely about that.
Yeah, it's very interesting. That exact question is a great question. And in my experience in the literature, it's always brought up in the discussion and never in the results. And so I think a great place, but we do see different health risks from loneliness versus social isolation, and at least in the geriatric population. And a lot of social isolation related risks are about functional decline and kind of barriers in that realm and frailty. And a lot of the loneliness related health risks are things like depression and dementia. Now there's some intersection over all of that, but there is an interesting kind of slight, non-statistically significant, kind of derivation there. And so I think it would be a great actual question, not just a discussion point.
Well, I think our intentionality is to leave some time for gathering out. My assignment for everybody is talk to each other, interact a little bit if you want to. If you don't, that's fine.
Yeah.
But I would like to just extend a heartfelt thanks to our panelists here. You guys were wonderful, and you took this on without any complaints. And Tracy, you came back directly from your honeymoon, put together your PowerPoint slides in the last 24 hours. And
no, I was thinking about him before that. I didn't throw it together. I have handwritten notes from my plane ride. Okay. Could we also shout out our friend Jenny, who ran this because normally I would? Thanks, Jenny.
ASL interpreters.
Yeah, thank you.
And Jenny, is everything?
Yes, please head out to the atrium to enjoy a dessert bar and some beverages.